Thank you, Steve, for the introduction. It's always a great pleasure to come to Canada and to be here for my second time in Vancouver and to be invited to share some ideas with you on the subject of patient safety. And my title this morning is Time for a Little Something. And you may recognize where this comes from. Can you put your hand up if you recognize which important medical text I've taken this from? Well, it's here. It's now some of you, because I didn't want people to sit through the whole 40 minutes thinking, I've heard that somewhere, but I can't quite remember where. The Pooh books, as you know, are full of all kinds of profound philosophy. And I realize that some of you may now be thinking, okay, so I got out my bed early to hear some woman from Scotland telling us about Winnie the Pooh, but in fact, it's just that little piece of phraseology, I think, well, it remains to be seen, captured what I wanted to say today on the subject of time and on some little somethings that might be useful in a time context and a time-pressured context that might be good for patient safety and also for worker safety. So my disclosure is that I unfortunately don't have any significant commercial sponsorship for what I'm doing here. I am a trustee of the Clinical Human Factors Group. This is my only healthcare affiliation. This is a charitable group that was set up by a man called Martin Bromley, who's an airline captain whose wife died in an anesthetic accident. And Martin was so troubled after the accident was investigated and shown to have failures in non-technical skills and other human factors aspects. He was very troubled to learn that in healthcare in the UK at that time, very little was being done in terms of developing an understanding of human factors and why that would be important in a high-risk environment, because it was so important in his world of aviation. So some of you may already have been on this website. He set this charity up with the support of academics, clinicians, pilots, and I would just say if you're looking for resources on human factors, these are free to download. There's a whole set of resources there. And some of you may have seen the video that was made after his wife's death, which is called Just a Routine Operation. His wife was in her mid-30s. It was very minor surgery she was going in for. She never made it to the operation because there was a problem with intubation that caused her death ultimately. And I wondered how many people here have seen this video, this reenactment with actors playing the story. Has anybody seen this? Oh, a few people, but not lots of people. So if you're teaching patient safety and you're interested in what I'm going to say about time and how you can get sometimes a bit sucked in the task and lose track of time, this video is a very good reenactment with great teaching points that you can use here. And you can get the video for free off this website or off YouTube. And just in passing, I was visiting, I do some work in aviation. I was on a military aviation base in England where the Tornado pilots are based, the fast jet pilots. I was asking them about non-technical skills training. And they said, and we used that video of the anesthetic accident. And I said, with the fast jet pilots, the Tornado pilots, you're using a medical video, a healthcare video, and the trainer said, yes, because it's all the same stuff. And so it's an important point. I work in industry more than I work in healthcare, that the same kinds of things catch people, and the same kind of things are good for catching error, whether you're flying a fast jet or whether you're in a clinic or a lab or a ward, and that's what I'm going to talk about. So, background, we are still concerned about patient safety despite various initiatives. This is a quote from our previous Secretary of State. I've taken English data, of course, rather than Scottish, because everything's very lovely in Scotland, as you might imagine. But in reality, there's not so much difference. And as a result of this and other concerns, ongoing concerns about maximizing patient safety, we have had recently, again this is for England, a consultation on a national patient safety strategy for the NHS, which is an absolutely enormous organisation serving a population of about 60 million. And the clinical human factors group took soundings from the clinicians that we are associated with, and one of the things we fed back in our response to this was, while there were very laudable patient safety strategies there, one of the things that's of concern is that there are underlying problems to do with things like resources and staffing that need to be addressed. If people do not have enough manpower, do not have enough time to do things properly, it's all very well having all these other kind of initiatives, but we have to address some of the fundamental problems which may come down to the responsibility of the taxpayer at the end of the day. This is another report that's just come out. For those of you interested in safety culture, this is quite an interesting report to look at. It came out in a few months ago in December. And one of the findings here is to do with why are people not implementing new standards, trying to standardize procedures. One of the findings that comes out of here is lack of time. You could say this is an excuse, but I think from what we're hearing, this is a reality. So I don't know if this would apply in Canada to the same degree, if you have this sense that in places your healthcare system is becoming increasingly stretched and people are having to try and do more with less and do things, in a sense, faster, better, cheaper to keep the whole system running. But I suspect in parts of your healthcare system, you'll have some of the same issues. And wherever you are, we can have error that causes adverse events. So my model of what we want to look at here is that there are factors to do with the culture and the workplace and the work conditions, and then a lot of the work I've done is to do with behavior and non-technical skills. And we have to look at both. We can't just look at one and not the other. And so the piece then, just to say a little bit about what kind of work conditions lead to error, become error enforcing. I just made the next slide up from most of the work I've done in healthcare has been around operating theatres and listening to operating theatre staff. And for another presentation, I was trying to get across the point about, well, what would be the characteristics of a bad day in theatre, or things that were suggesting this was not going to be the easiest, smoothest day. So things like, if we're trying to make a recipe here, 2 grams of equipment malfunction, 1 gram of missing equipment, maybe somebody's borrowed it and not put it back or wherever it's gone. Maybe some fatigue, 4 tablespoonfuls of fatigue per person in this team who are about to start working together. Maybe a little bit of friction is existing from what has happened earlier this morning or the previous day or some pre-existing issue. Maybe somebody's a bit grumpy because their car wouldn't start or something else has gone on that's nothing to do with any of this. And you put this into the mix. The mix here is quite a strong status hierarchy. We might have a delayed start to the list that's going to agitate people even further. We put on some more time pressure. And in a sense, we can just wait for boiling point, because these are a whole set of conditions which may make it easier for errors to occur and errors not to be detected. And I've highlighted the time components because it's the time component that I want you to think about here this morning in this session, and how this might affect your work, whether you're a manager, whether you're an administrator, whether you're a clinician. And for many of us, this picture of the Dali's melting time, if you're very busy and you've got lots of things to do, and there just seem so many things to fit in, and I'm sure some of you are feeling like that this morning, then this kind of image of the melting clocks may be relevant. But we've seen a number of accidents across different domains where time has been a key factor, or lack of time. I don't know if you remember, some of you may have seen the film Rogue Trader. This was a British bank, the oldest British merchant bank that was over 200 years old, who had a trader, Nick Leeson, in Singapore, who seemed to be doing extraordinarily well and making lots and lots of money for the bank, and everybody was very happy. But in fact, what was going on was he was making those, he'd got himself into a little bit of a financial situation he shouldn't have been in. He broke some of the rules, and then he continues to break more of the rules by starting to put the bank's money into these trades that he was making, ultimately losing the bank something like £2 billion, and the bank then collapsed. And what's this got to do with time and healthcare? Because one of the senior managers, I think it was the group treasurer, said when asked, why were all the warning signs missed? There were audits, there were safety systems, there were a whole set of things you can imagine in a bank in place to stop this kind of thing happening. He said why he'd missed them was because there always seemed to be something more pressing to deal with than these little warning signs that were coming over his desk. And I'm sure some of you, particularly managers, may kind of sympathize with this view. But it's saying something about the state of potential complacency here, being too ready to accept that everything is going extremely well and not being sensitive to the fact that the risks always remain. And there have been some other, NASA Columbia, you may remember this one where the shuttle came in and caught fire on entry because some tiles had been knocked off by debris, protective tiles, on the way up when the shuttle was launched. And the analysis of this is interesting because part of what was going on was massive schedule pressure to get things done. NASA was under a lot of pressure in those days, strong incentives to move forward and look askance at anything that was going to disrupt the schedule, like warning signs about things. In the report, the admiral who led this particular investigation said it was more to do with holes in organizational decision-making than holes in the wing of the shuttle. So it was an interesting quote. And a very interesting book that was done afterwards called Organization at the Limit presents this theme that was a mantra that an incoming manager had brought in to kind of speed up things, particularly on the Mars program. But the mantra was faster, better, cheaper. And the analysis in the book is how the pressure that this created with people trying to do this caused, or was one of the contributing factors to the accident. Because what happens with that kind of pressure is people start maybe not following the procedures so much, maybe cutting some corners, maybe doing some workarounds, maybe taking a little bit more risk. And your organization at this point is drifting slowly and imperceptibly towards the kind of safety margins where an accident is more likely to occur. In another NASA study, this one is a fixed-wing study, this is aircraft, the kind of aircraft that the rest of us fly in. It's quite an old paper, but this was an interesting one because they looked at a series of accidents, aviation accidents, I'm not saying major ones, but things going wrong, and found that in half of them, the pilots were behind schedule. And they kind of called the behavior pattern that they were seeing, this phenomenon of pilots then rushing to get away from the gate, which is a big key performance indicator for them. They called this the hurry-up syndrome. And this is a nice phrase. I don't know whether you can see in some of your workplaces the hurry-up syndrome maybe coming into place. And you can deal with this by better planning, better preparation, and trying to resist the imposed time pressure. And people put time pressure on themselves. It's not always coming from managers. People want to finish things by the end of the shift, by the end of the day, not hand over something, show how competent they are. You can self-impose time pressure, which may be part of the problem. So what I'm arguing here is that I'd like you to just think a little bit about time as a safety resource. And the managerial issues here, for those of you in management positions, is how much time is there in your system for quality and safety. This is a huge, very successful quality and safety meeting, and you have time at the moment. You have 2-3 days at the moment, but you're going back into the workplace. And when you get in there, do you have enough time to do the things that you want to do? Or is there time for training, time for task debriefing, time to do simulation exercises, ergonomic risk analysis of your workplaces? Are there production pressures of getting things done, meeting targets? We heard yesterday about the waiting list targets that we have, the waiting time targets we have in the UK in accident and emergency, and what problems that can cause. Is there enough staffing? And do people have permission to slow the job down? Is that encouraged in your workplaces that people should do that? And that's a little bit I want to talk about now when I start to look at behaviour. So I said I have this kind of model in this framework I use. And the second piece I want to talk about is to do with behavior, and the work I've done as a psychologist has been to do with non-technical skills. And these are people's thinking skills and teamwork skills. And it's only in recent years in healthcare that these have been particularly identified and been used for training. And we've worked, as I said, mainly in the area of surgery with the different members of the surgical team. And surgery is an interesting area. That's traditionally an area, not surprisingly, because we didn't have anesthetics for the patients, but this is an area where speed has been very valued, and that may still be part of a hallmark of some surgery today. And this is a little story I came across about a famous, eminent Scottish surgeon who was having a particularly bad day in theatre, where instead of having one person die, the patient, which would have been 100% mortality rate, 2 other people died as well. And what happened was he was doing a very fast amputation in 2.5 minutes. The patient died later because of gangrene. So if he didn't die in the operating theatre, the infection got you once you got back to the wards. But accidentally, while he was doing this very speedy amputation, he accidentally amputated 2 fingers of the assistant surgeon who was working with him, who then also got gangrene. We must have had a lot of gangrene going about in Scotland at that time. And then he also slashed the coattails of one of the coat of one of the observers, who thought that he had been fatally wounded, and then he had a heart attack. So this was it's a kind of, I don't know the full truth of this story, but it's in the literature. So this was clearly a time in surgery where speed was very much valued for obvious reasons, but could have some undesirable consequences. And surgeons weren't spending a lot of time worrying about their non-technical skills in the early 1800s in Scotland, as far as I'm aware. So non-technical skills, and how many people are familiar with this term, or are doing any work in this regard? Can you put your hand up if you're, just to get a sense of how many people? So a number of people are familiar with this. So this is coming from aviation. This has been around in aviation for 40 years, once they discovered that accidents do not always come from technical failures. It can be the way that pilots are working together, the way they're communicating with air traffic control, can be to do with decision-making and teamwork and leadership. And once that was realized in aviation, they did a significant amount of scientific work to identify what were those skills and what were the behaviors that would indicate those skills were being used. I've worked in aviation and was lucky enough to work on a European project identifying non-technical skills for pilots, and took the methods that we used and began, as the patient safety issues began to emerge in Scotland about 20 years ago, began to work with anaesthetists and surgeons and nurses to identify what would be the non-technical skills for a surgeon while operating, or a scrub nurse, or an anaesthetic nurse, or an anaesthetist. And I'm not going to go through this work. And the skill set, if you've not seen it, has these main categories: thinking skills, situation awareness, and decision making. And then these social skills of leading the team, working together, communicating, and also in these environments being able to cope with stress and fatigue, which are not entirely uncommon. And so the work we did resulted in a series of booklets that we made. I've got a couple of copies here if anybody's interested. I don't particularly want to carry these back across the Atlantic. But there are websites for each of these tools where you can access the booklet itself. We've made them freely available for non-commercial use, so you can download these and use them for training or just have a look at them with your teams to discuss the behavior. So there's one for anaesthetists, there's one for surgeons, there's also a book. We had to help the surgeons understand all this psychology better, so we wrote a book with surgeons as well, explaining it. One for scrub practitioners, that's nurses and operating department practitioners who work together scrubbed in, and also one for anaesthetic nurses. I know in different countries this is different, but these are nurses specially trained to work with the anaesthetist. They don't give the anaesthetic, but they're like the scrub nurses for the anaesthetist. So if you're interested in this, or some people have emailed me to say that they'd like to talk about this, I'm here for the rest of the day and happy if anybody wants to know more about non-technical skills or how you bring this kind of framework in. And these are being used in resource-limited countries as well as in developed countries. So we know, for example, that surgeons in Africa are using these kinds of tools as part of their training. I was a little bit surprised to hear that because I thought they had, you know, if they're in such resource-limited conditions that maybe non-technical skills wasn't going to be top of their agenda. But apparently they explained they have such inadequate aftercare and such limited resources that they have to get it right first time in theatre. So they really can't afford to make error. And anything they can do to reduce the results, reduce the risk of error or adverse event, they're prepared to spend the time on that, which I thought was a bit of an eye-opener. That was kind of interesting that they saw it in that way. And this is, of course, a very low-cost intervention, although it takes some time. So what I'd like to say is, now is to look a little bit at time and human performance. This is probably unreadable, but this is from a study that we did with charge nurses. So these are the nurses in charge of wards in the UK. This was in Scotland. And we were looking at nurses' leadership styles and how that affected patient safety. The paper's published if anybody's interested, but I had just extracted some quotes from this, which I realize you probably can't read. You can have the slides afterwards if anybody wants them. But in this interview work, we had these charge nurses talking a lot about being under pressure. And also, they saw as part of their job was to take the pressure off their teams, which actually then puts more pressure onto them. They also saw themselves having to come away from their administrative work to help with tasks in the ward. And we were interested, we were using a leadership scale that looked at how much time they were spending on kind of change management, quality initiatives. And what we were finding was, at that time, they were spending so much time trying to get the tasks done in the ward and keep the teams happy that they had little time left for kind of quality or change initiatives. And so it was kind of an indication that the nurses in particular here were experiencing time pressure. And I did read a quote in the Vancouver Sun from last month, nurses who were negotiating a pay claim, talking about they might rather have more staff than more money, which I thought was an interesting quote. Now this is a paper, this is probably gobbledygook what's on this slide, but this is in essence what I want to talk about now, is about slowing down tasks and whether you're allowed to do that and whether people know how and why that's important. And this is a study, again, from nursing. I don't know which country, it's not the UK, probably the US. And it's nurses, what this is about, it's about mindfulness, which is really meaning situation awareness and concentration on the task. And what the argument here is that the nurses that they were working with told them that if they had to adhere to the procedures very carefully and follow the rules, they were then worried that they weren't going to get all their tasks done for the rest of the day. So what do? They do workarounds and they cut corners to fit things in. And we know workarounds and cutting corners are very good for error. And in this study, they were looking at nurses who were reporting more mindfulness. There's a whole literature just beginning to emerge in the safety literature, including the industrial safety literature, looking at mindfulness. I think it's really about situation awareness, but it's about mindfulness is concentrating on the task, not necessarily tuning into your inner feelings kind of mindfulness, but just being fully attentive to what's going on here and now. And they found that the nurses who were doing more of this mindfulness and less worrying about future time problems were doing less workarounds and were doing the jobs properly. And it may be that those nurses who do that have a little more concern about safety. They're a little more aware of where the risks are and why it's important to make sure things are kind of done by the book. And there's some data, they collected some data. Again, you probably can't see the numbers on this, but they found that where there were more mindfulness, i.e. they were then following the rules, doing the tasks slightly more slowly, then there were fewer workarounds. If they had fewer workarounds, there were less injuries. These are injuries to nurses. These are needle stick and back injuries. So this isn't injuries to patients. Nurses get injured also in the course of their work. And so this whole piece about mindfulness and situation awareness led me to think about some work that we had been doing around how do surgeons make decisions. There was very little literature on this. As we began to look at non-technical skills for surgeons, it's pretty clear that surgeons make decisions while they're operating. First of all, they tell you that they make all the big decisions before they start. But things, for any of you who work in operating theatres, things do not necessarily always go to plan. Something may get cut that wasn't supposed to be cut. The anatomy may not be quite as you expected. The tumour may not be quite in the place you thought it was. The bone may be of a different shape. All that stuff causes surgeons to have to make decisions while they're operating. And this was interesting us, and we began to interview surgeons about taking decisions while they were operating and what kind of method of decision making they were using. And we put the work together into a framework that we'd already seen from aviation, from NASA, looking at how do pilots make decisions when they're at 35,000 feet in the middle of the flight. And what's important there is how much time they spend on situation assessment, is working out, not just working out what the problem is, but part of their expertise is working out how much risk is there in this situation and how much time have I got to think about it. Do I have to do something right now, or could I spend a minute or two more thinking about this before I do something? And this interested us, and the surgeons told us, oh yes, that makes sense for us. We published this in a journal article about this idea of thinking about available time. And what the model's saying is how much time you've got drives the kind of decision-making you can do. The kind of decision-making method. Are you doing the fast, automatic, intuitive stuff, or the slower, more analytical kind of decision-making? And surgeons use both of those styles while they're operating, and the rest of us use both of those styles when we're doing whatever tasks we're doing. So the difference between these styles is that the automatic, intuitive, I've seen it 100 of times before, I know what's happening here, I know what's going to happen next, I'm very comfortable with this, I hardly, I'm driving to work, I've driven this way 72 times or 720 or whatever. I'm an automatic pilot, I know what's going on, I don't have to use a lot of my brain power here. And that's good, the brain's designed to do this when we have familiar things and we're comfortable. But sometimes we have to spend a little bit more time. If we're doing mental arithmetic, for most of us, that requires some concentration. Nurses counting swabs or instruments have to concentrate on what they're doing. And then we start to use these more effortful, sometimes more analytical styles of thinking, particularly if we're choosing between options for things to do. And there's been a number of publications on looking at these, particularly the faster and the slow styles of decision making. And this work by Kahneman, an American psychologist, and his colleague Tversky won them the Nobel Prize. We don't have a Nobel Prize in psychology, so they got the Nobel Prize in economics. And this book's all about, you find this book at the airport, about thinking fast and slow. So we all do this. We use both these styles. The brain's designed to do this. We're comfortable with this. But the question that's interesting is, what causes you to switch from one style to another? And I came across a number of years ago some work I thought was really fascinating. It's Canadian work, you'll be pleased to know, not from this province, but from a Canadian HPB liver surgeon in Toronto. She did a PhD, most unusually for a surgeon, did a PhD with a psychologist as a supervisor and studying, she was actually studying, Carol Ann Moulton, her name is, some of you may have heard her speak about her work. She was studying how do surgeons make decisions when they're operating, and she is a surgeon, so she was watching surgeons, interviewing surgeons, and what she found was that experienced surgeons, the more experienced surgeons, and this would apply to the more experienced nurse, pharmacist, physiotherapist, whoever, know when to slow down, to switch from this fast automatic, I know what I'm doing, I know what's happening here style, to the, whoa, I think we need to just take our time here, have a look at this. And this can happen in two ways for the surgeons. They may, when they plan the operation, already know that there's going to be a tricky bit halfway through, or when they get to a certain vessel or a certain structure in the anatomy, and they're going to have to be really careful at this point. So they may have pre-planned when they're going to have to slow down, or something may happen that they're not expecting, they hadn't planned for, and they're going to have to think about this much more deeply and consciously, using more of their brain power while they're doing that. And here's an example from this book we did with the surgeons, mainly, the chapters are mainly written by surgeons. This is a quote from observations of surgeons, a transcript of surgeons operating. They're general surgeons, I think. So the consultant is working with a trainee surgeon and says, where's the hole? Can you see it? Well, that's no good. If you can't see the whole hole, we can't repair it, can we? He's not having a good morning now in theatre. If you can't see it, we have to put a clamp on. Another vascular clamp, please. But then he says, right, think. Let's just think here. And then he says, this all started off so nicely, didn't it? Now, this is a tiny little quote, but it tells us lots of things about thinking skills. It's telling us lots of things about this slowing down phenomenon that we're becoming interested in. So this phrase, suddenly, he's saying, oh, you know, we thought we knew what we're doing. Now we have to really concentrate here. Right, think, let's just think here. This is just his normal language. And this all started off so nicely, didn't it? Suggests this was quite, I don't know, but this was quite a routine operation. We knew what we were doing here. This was going to be really smooth and straightforward. We were going to get through this case quickly. And from Carol Ann's work, and from one of her papers, there's a similar quote with the same kind of phenomena being, she's calling this surgeons plowing through. This must be a Canadian spelling of plowing, but so the quote here is, this is surgeons talking. I think the other time you get burned, it's the easy ones, because the difficult ones, you're going slow all the time. And that's exactly what's happened here. I can't do the Canadian accent or any other accent apart from a Scottish one, so I just carry it. It was an easy lobectomy. You're not going slow, you're maybe chit-chatting, you're maybe not paying as much attention. Because when you're in that fast, intuitive, automatic mode, you've got some brain capacity to do other things, like have a bit of a chat about whatever, and you are using that spare capacity to do other things, and in this case have a chat. That's quite normal to do that. But then suddenly something's gone wrong, and they've carried on, they've missed the warning signs here that they should be slowing down. And so that's one of the key questions here, is how do people learn to recognize what are the warning signs that you should be now slowing down the task? Again, from Orisanu's work at NASA, they did some work about pilots. Certainly, you might not want to hear this stuff if you fly, but pilots, pilots in the simulator, I hasten to add, but showing a behavior pattern, and many of us will have done this in our own tasks, whether it's driving in snow or driving or whatever. And they call these planned continuation errors, and they also talked about goal seduction. This is when you get really near the end of the task. What they found is you're more likely to tolerate more risks. You know, ever been really near the airport, a bit late for a flight, the road's a bit slippy, but you just carry on when you maybe should have stopped or slowed down because you need to make the plane, that's what you're... Anyway, so they were in the simulator, the pilots were flying a leg, they began to give them problems and noticed that the nearer the pilots got to the destination airport, the more likely they would be to tolerate more risk. And carry on to that airport rather than doing a divert. And doing a divert is a huge hassle for pilots because they have to replan everything. It's going to give them a load more work. The passengers are really unhappy because they thought they were going to Winnipeg and now they're going to Toronto. My geography's not great in Canada, but that's maybe not a normal divert pattern. But you know what I mean. Everybody's a bit unhappy here, but at least it's going to be safer. You know, if you're sitting in the back and that. And they found some factors to do with risk tolerance. And again, we may have this slight, have we got enough uneasiness about the risk here affecting our behavior. So this is my message this morning, is about thinking about what do we have in place to encourage people on task, on clinical tasks, to slow down when they need to do that. Are we teaching the skills? Are we encouraging that behavior? Here's an accident from this is from a drilling rig. It's in European water. I heard this. The company in question made a very nice little video animation thing of this accident and shared it at a drilling safety conference last year, which I thought, all credit to them for doing that. And what happened here was, in its essence, and I'm not a driller or a drilling engineer, there are a team who are lifting a heavy seawater pipe, and it's kind of above the sea at the edge of a piece of platform, and it's on a big heavy sling thing that they're lifting this up with it, and it gets stuck at one point. During this lift, it gets caught on a ledge. So first of all, one man goes to push this thing away from the edge, and he doesn't have quite enough strength. So another man in the team, he stops what he's doing, and he comes to help. To push, and they still haven't got it, but it's nearly moving. So the third man in the team, he comes, and then they all give it a push, and then at that point, the sling breaks. The seawater pump falls suddenly, it's a huge pump, into the sea. There's some cables and things. One man is taken into the sea with the pump and is killed. Another man is badly injured. And what is interesting for me in this context about this horrible accident, and there's an accident report from the Norwegian Petroleum Director, if anyone wants to look at this kind of thing, but what's interesting here is the opportunities that may have been there, of course I wasn't there, to slow the job down, because the task is changing. This is not the plan, as people were going to be pushing the pump. So first one person does it, then another person, then a third person. But nobody has said, could we just stop a minute and think what we're doing here? Is this risky in a different way we haven't thought about? And in the drilling industry just now, particularly since the accident in the Gulf of Mexico, Deepwater Horizon, some of you might have seen the movie, where they certainly didn't slow the job down and stop what they were doing and think about it. The industry has been very emphatic about people stopping the job, and they have all these stop the job campaigns, and you can put your hand up and stop the job, and there's a lot of emphasis on this, but these are humans that are working there, and of course, like the rest of us, they don't always want to make the fuss of stopping the job. And I've been suggesting recently that maybe what we need to think about more is about slowing the job down. Not a great big dramatic stop the job, but could we just pause the job for a minute and have a quick chat, have a conversation, have a risk assessment. And so what I'm thinking about here is slowing, what are the slowing down cues? And one of the drilling managers I talked to this in the last week or two, he said, oh, we could work with the crews and we could get what for them would be the right cues that they should be slowing down. And I'm just wondering if you're looking for tools, if this is the kind of thing for your particular clinical domains, are there slowing down cues? Things like something unexpected, the plan isn't working as we thought, the team seems to be a bit confused about what we're doing, the task's more difficult than normal for some reason, or the equipment doesn't fit quite, whatever. So I think there's things about slowing down cues. And a version of this that we worked on a little bit with, this is a German anaesthetist. He came up with this idea, Markus Rahl. He was working in the simulator at Tübingen. He was very interested in human factors. And he said in the simulator, they were teaching this mantra about 10 for 10, that 10 seconds pausing, thinking what you were doing or gathering more information could probably save you 10 minutes in the time of the whole task. And he did say, actually, that could save a patient from 10 years or more of misery if we get something wrong when we're anesthetizing or when we're operating. And so this, and I realize that this is not a new idea, and some of you may have your own tools for this kind of thing in your own workplace, but 10 for 10 was what they were using in the simulator. I've talked a number of times here about some people seem to be less complacent, less comfortable if they're working in an environment with risk, and healthcare is full of risks, both for patients and staff, that some people are a little bit more aware of the risks. And we had a piece of work a year or two ago with Shell, the oil company. The oil companies post-deepwater were very concerned about not having complacency and everybody being well aware of the risks in oil and gas. And they had taken this term chronic unease, which comes from the high reliability organization literature, and we did some work looking particularly at managers. They did some work with the workforce looking at chronic unease and saying a little bit of unease, if you're working in a high-risk environment, is a very good thing to have. And some people seem to have a little bit more of this, and it probably is part of expertise building up this. And because I've become interested, I looked for examples, and I saw just this month a quote. It's a neurosurgeon in London. He's written a couple of popular books about his work as a neurosurgeon. And I saw in a newspaper article, it was an article about how do people cope with stress. And he said, as a neurosurgeon, I was in a state of mild chronic anxiety all the time. So, and he's worried about what can go wrong and how he's going to deal with things when things go wrong. It's a senior neurosurgeon clearly doing difficult surgery. And then there's I found another example. This is a surgeon, a head and neck surgeon, another one. And he's saying, this is a quote out a different newspaper last year, saying the truth is sometimes I don't switch off. I ruminate and I think about patients, often awake bolt upright at 2 o'clock in the morning, remembering something I've forgotten about a patient. I'll send an email. What happened to so-and-so? And this intrigues me. So this, I'm asking, is this chronic unease a little bit? He's never completely comfortable that it's all gone right. Something could have gone wrong. They might have forgotten something. And what seems to be happening here is that there are processes in the brain, we think, that are subliminal, maybe slightly unconscious, that are sort of monitoring what we are doing and occasionally bring us back. If you've ever got up on a Saturday morning, got in the car to go to the supermarket and started driving the route to work, and then suddenly you realize, no, I'm not going here, I'm going here. Something has made you suddenly realize there's some monitoring going on where something is said, you've noticed something, but there's probably some underlying monitoring saying things are not quite right. And I was asked recently to examine a PhD that is a very interesting PhD with a student who had come up with a new concept all on his own that's very much related to this, which he called latent error detection. And this man this was at the University of Southampton. His name's Justin Sayward. And he was an officer in the Royal Air Force and was an aviation maintenance engineering specialist. And he had become interested in a phenomenon that he was aware of, where sometimes when people had finished the task, like servicing an aircraft, which is a pretty important task, afterwards they would remember, oh, I forgot to put the cap on, or I was meant to check another pressure here and I haven't done it. And I've started to ask surgeons sometimes, have you ever had cases where and other people, have you finished the task? I've done this, and you finish something, and then minutes or an hour later, you get out your car and think, oh, don't think I got paid for the parking. I need to go back and do this. And again, there seems to be some kind of monitoring going on. That makes you think about this. And he called this latent error detection. The book's just come out of the thesis. There's a paper about this. And I think this is interesting. He found that he studied these maintenance engineers, these aviation engineers. Mostly, if this happens, it's within about 2 hours of making the error. It's most effective when you're still in the workplace and probably something catches your eye or makes you think about it. But for some people, they'd gone home or were driving and then suddenly thought, oh, I wonder if I did this, or I know I didn't do that. If you deliberately review what you've been doing, this helps you pick up those errors. They found that having physical objects that they were using in the maintenance tasks were quite helpful, but I don't know what, spanners or oil cans or whatever these guys use. And he did a little bit of work starting to test out how you could encourage people to do this. It's another very quick way of prompting people to think about an error that's still got the potential to be caught and remedied. And he talked about in his thesis about it's as if our brain is doing a little bit of cognitive housekeeping after we've finished the task. So we've finished with it, but some bit of our brain is just kind of thinking over the task to make sure we did. I don't know what's going on there, but there's something going on that's interesting. So I have run out of time badly now, and as my last slide. And so I've changed my title now slightly to A Little Time for a Safety Something. So what I'm suggesting here is, are there maybe some really quite simple interventions that could be designed in your workplaces about the following: having a safety pause, hesitating, the 10 for 10, 10 seconds might save you 10 minutes or the patient 10 years. Something about slowing down the task, not saying to people you have to completely stop the job, but really encouraging people that the task, it's a good idea to slow the task down and when you might have to do that. Maybe times where you need to be aware that you should be thinking more slowly and recognizing the cues. And then this new idea about what maybe some simple things to help people just review complex tasks after they've done them and think, oh, was there anything we didn't do there that we could still fix? So thank you very much for your attention. I'm now 4 minutes adrift here, and I hope that was of some interest. Thank you.